I see that my family's here. Thank you. And indeed, you are, yes. So we've had some very inspirational speakers. So that's normally why I'm higher up in the program, because all the better speakers come after me. So I'm going to try my best. So I wanted to spend a few minutes and talk a little bit about how the treatment of advanced lung cancer is changing. And it is changing. And I think every year when I sit down and try and put together the topics for discussion, there are some new things to discuss. For this year, of course, number 4 is going to be the highlight, which is the new modality of treatment for lung cancer, which is immunotherapy, which is not quite approved yet, but is pretty much on the way. But we have now seen, in my time as an oncologist, better chemotherapy with newer drugs to treat the side effects of chemotherapy, adjuvant chemotherapy, which is giving preventative chemotherapy after surgery, is a totally new paradigm in lung cancer as of maybe about 10 years ago. Targeted therapy, or otherwise referred to as personalized therapy. And then lastly, immunotherapy. Okay, so when you think about lung cancer, and I look at it from, as I get older, I can say when I was younger, and I went to the national meetings for lung cancer, and you walk into a lung cancer room with all the people that are interested in lung cancer research. There may have been about 10 people in the room when I started. Now you can't get into the room because it's an area of extreme excitement and novel work. So what are the current goals in terms of treating a lung cancer person? Is to design a unique therapy which is individualized. And hopefully you're going to find somehow to target the cancer cell and spare the normal cell. And we can do that now in a lot of patients, not everybody by any means, but in a lot of patients. So for us to be able to do that, we have to be able to understand a little bit about the cancer itself, about the molecular pathways, so what led to this cancer to develop in the first place, and that may help us to identify what the targets are going to be for our treatments. So now, how do we individualize care? We can do a couple of things. We can first of all look at the person and look at some of the factors such as gender, such as the cancer cell type. Interestingly, the cancer cell type, again, when I started, it was, non-small cell. It was classified as just one category. But within non-small cell, there were 4 or 5 different subtypes, and we all felt that they were all the same. Well, in fact, it's not true. So now, years later, we now want to know exactly what is the cell type. And I mention that because lots of places in the US still do not look at that. And non-small cell is treated in the same kind of ragbag by several places. It'd be very surprising. The days when I used to travel to speak, I would still come across this, and that you should not see anymore. And that may imply that we have to do a better job at getting biopsies, that we have to be able to get maybe bigger biopsies to let the pathologist know, or we have to have better pathology. So we tend to try and individualize care by looking at the patient first, and then to some tests to help us identify what we can treat. So I put in the list here in the first, where's my arrow? Okay, where's the arrow? Here it is. Sorry. So we put in EGFR, ALK, and RAS. And so you've heard from Laura that in her case there was a mutation in the epidermal growth factor receptor, EGFR. And that allowed us then to treat with a drug to target EGFR. So now the list of potential targets has expanded significantly, and now we can look at, instead of just 3 genes, we can look at 200 genes. And interestingly enough, you know, as we do this more and more, and we identify drugs to target individual genes, that's going to increase the armamentarium significantly. We also learned that not all cancers, some cancers may share the same molecular targets. So for example, some lung cancers have the same molecular targets as melanoma or breast cancer. And if you can measure and you can find it, then you can use a drug that is being used in breast cancer or melanoma to treat lung cancer and has been shown to be effective. So this is the new world, right? And ever since I've put this slide up, every day there's a new gene with a new target that's identified. Now we look at ROS, we look at many other things. So the concept here, music. So the concept here is to take the group of non-small cell lung cancers, and we go from thinking that it's all a homogeneous group to recognizing, in fact, it's a heterogeneous group. And the heterogeneous group means that within the big group, there are folks that will do well with one therapy. There are folks who will not do well with another therapy. And it's our job then to try and identify who is who, and so therefore we can treat the cancer better. And we're not there by any means, but we are closer than what we have been. Okay. So this is a slide I borrowed from the Lung Cancer Mutation Consortium. And this was a consortium that was formed by several centers. And what they did in real time, okay, in real time, when you get a biopsy, they send it for extensive molecular or genetic analysis. And I tried to identify what are what's called driver genes or driver mutations, the genes that were responsible for the cancer cell to grow in real time. And if they identified a specific aberrant gene or a mutation, then that person was treated with the drug to target that specific gene. So you can see here that the vast majority are still unknown, okay? So we have a lot of work to do to identify that subset. But in the other, I don't know, I'm really bad at arrows. But here you have, so a certain percent had epidermal growth factor, which is probably still the commonest driver mutation we know. We have some lung cancer that have HER2, which is very common in breast cancer, the ALK, the BRAF, and melanoma. So as we begin to tease this out, there'll be more ways to treat lung cancer in an individual way. So subtypes of lung cancer, so I think we talked a little bit about that in the beginning. So adenocarcinoma, which means that the cell looks very glandular under the microscope, is still the commonest type of lung cancer. Squamous carcinoma is the second commonest type of lung cancer. And this is how it looks under the microscope for the pathologist. Interestingly now, we have specific treatments for adenocarcinoma. So most of these molecular targets I mentioned to you were seen first in adenocarcinoma. Squamous carcinoma used to be commoner maybe 20 years ago and is flipped around now, second commonest. So all this is what comes under non-small cell lung cancer. A very interesting paper that just came out that looked at patients with squamous carcinomas was described in that certain individuals with squamous cancers that have never smoked have the same profile as adenocarcinomas. And in fact, you can use targeted drugs to treat those folks as well, and I have a couple of patients like that in my practice. All right, so we talked a little bit about epidermal growth factor receptor. That probably is the first target to be described for which there's a drug to hit that specific target. And as you can see, this is a schematic of a cancer cell. And the epidermal growth factor sits, oopsie, did I move? Yes, I did. Sits on the surface of the cancer cell with a portion of it on the outside of the cell here and a portion on the inside of the cell, right? So So what happens is, think of it as a receptor that binds a specific hormone and sends a message to the cancer cell to grow. So the epidermal growth factor receptor is also part of the HER family, so it's actually HER1 in lung cancer, HER2 in breast cancer. It's part of the same family, okay? So the first drug to be looked at, and it was discovered actually quite accidentally. If you remember, those of you who can remember Iressa, Iressa was a drug that was described as an EGFR inhibitor and was being tested, and that was the first description of a subset of patients that responded very well to this drug. And it was before that, nobody had seen anything like that. And interestingly, when you looked at the subset, it was women who had adenocarcinoma who had never smoked. So the first description of this drug working was in that certain subset. It was only after that was defined that people went back and said, well, why is that the case? It is the case because in that group of people, there is this predominance of this EGFR receptor, and the drug inhibits the EGFR receptor. So since those days, Iressa is no longer available in the US. It's available in Europe and Japan. But Tarceva or erlotinib has taken its place. And this is where it works. It works on the inside of the receptor and inhibits the message from getting into the DNA and for the message of growth, right? So that was the first drug to be defined. And over the past couple of years, there has been significant advancement in the understanding of how this works. And now there's a second drug that was also approved by the FDA not so long ago, in June, July, and the drug goes by the name of ifatinib or Gilotrif. And ifatinib is another EGFR inhibitor, which showed, in fact, when you compare it to chemotherapy, it's superior to chemotherapy, but in a very specific mutation in the EGFR receptor. So now we have two drugs to target this one receptor, and even more impressively, what happens if the drug works and then stops working, okay? If the patient develops a resistance to this particular drug, which does happen. We've now begun to understand there are several mechanisms that explain resistance, and there are now new drugs that are about to finish clinical trials that target the resistance to Tarceva or erlotinib, and they're also very highly effective. So we're going to see a generation of new drugs coming to target the receptor and then to target the resistance to the specific drugs. And the reason for that to happen is that we think that if you have this mechanism that is responsible for cell growth, even though the pill stops working, the cell is still dependent on that mechanism to grow, so you can hit it in a different spot, okay? So EGFR has evolved now from one drug to having about 4 or 5 drugs evolving in the pipeline. Not so far after that, there was the description of ALK. And ALK is another target. It was initially described in lymphoma, but about 5% of lung cancer patients have this ALK gene, which is also responsible for growth. And now there's a drug to target ALK. It's a pill and inhibits the ALK very well. Again, since the ALK was defined, now there's a second drug that was approved by the FDA a few months ago that targets ALK resistance to the first drug. And then there's a whole host of drugs coming on after that. So you can see then the molecular targeted treatment is evolving to design the drug to hit the target, to then design a drug to hit the resistance to the target. And so I think we may be looking at a time where we're going to be able to offer a succession of targeted drugs to keep the tumor in check, okay? As you can see on this diagram, however, the cancer cell can be pretty smart. They have other pathways for which we don't have as good targets yet. So you see here something called RAS. RAS is present in about maybe 30% of lung cancers. And that right now is the gene where we don't have a drug to hit, but there's a lot of interesting work. So for example, there's an understanding that RAS mutated lung cancer has a predilection for, it can actually metabolize albumin better than non-RAS mutated cells. And that gives them a growth advantage. It's a nutritional growth advantage. So one of the labs at NYU actually have looked at a chemotherapy drug called Abraxane. And Abraxane is Taxol, but it's combined with it's nanoparticulate Taxol, albumin bound. And I found that KRAS cells take up the Abraxane better than non-KRAS cells. And maybe that gives them an advantage, maybe that gives us an advantage in terms of killing the KRAS cells. So some of that work actually is ongoing right now. We're designing together a trial to put together Abraxane being tested in KRAS positive patients. Now, Abraxane is a drug that's approved for use in lung cancer, okay? But nobody's looked at it in the specific KRAS population. Okay, so this is ongoing work, and I'm not going to bore you with that. Oh, that's the elk. That's the elk slide. So the elk slide, basically, this is what's called a waterfall plot, which shows that if you have an elk mutation and you take this elk inhibitor, the majority of patients by far will respond to the drug with significant shrinkage of tumor. Okay, so you can see that we are coming to a world where we're going to look at a cancer cell, we're going to identify what are the driving forces for the cancer cells to grow, and then we're going to try and hit it with whatever drug to hit those targets. And then chemotherapy will probably still have a role because that can attack the DNA directly. So, but we're going to be looking at kind of individualizing treatment depending on the cancer. Okay, now, this is the hot stuff. Okay, so, you know, when I was a young kid, immunotherapy was the thing to do, right? And so why do cancers develop? Cancers develop because somehow they escape the immune surveillance, okay? So we all have an immune system, and this immune system then is supposed to be able to recognize cancer cells as being foreign and then kill those cancer cells, okay? So there's a lot of debate about, well, how foreign is cancer? Is it really not that foreign? And the immune system can't see it, and maybe the immune system gets tired. So in the early days of immunotherapy, the plan was to give drugs to stimulate the immune system, right? So I'm going to give interferon, I'm going to give interleukin-2, and in fact, you know, in my younger days, I did a study of interferon in lung cancer to see if I can stimulate the immune system to kill the cancer cells. Well, it didn't work, right? It didn't work. And so those immunotherapies done in the early days did not show much of a benefit. And why is that? Why is that? Is because the cancer cells make on their surface, at least in some of them, a receptor, and it's called PD-1. And PD stands for programmed death, you know, so great title. And so when you have a cancer cell that has programmed death receptor on it, and your lymphocyte or the immune cell comes to kill it because it tries to recognize it, this receptor blocks the lymphocyte, okay? So the name of this is a checkpoint inhibitor. This is an immune checkpoint, right? So it turns off your immune response. And so then the next phase from describing that is to design a checkpoint inhibitor, right? So right now then, there are several products that are directed against this PD-1 receptor, okay? So the first trial that was done with this was about maybe 2 years ago, and this is before the understanding of, you know, PD-1, but basically it was an antibody directed against PD-1, and it was given to patients with lung cancer where chemotherapy had stopped working, right? So you can imagine then if you give a couple chemotherapy programs, this is a population that the cancer cells may be a little bit resistant, right? So now you gave this antibody to PD-1, and what was seen is, okay, what was seen is that there were significant responders, right, in that very first study. And the interesting part about the study, when you analyze the data, the people actually responded better were the smokers, right? And there are reasons for this. But interestingly then, a certain fraction of the patients treated on those trials were still going on alive and well 2 years beyond. So now this is revolutionary, right? This is the first time we see something like this in lung cancer. So what do we know about this now is we know that if the cancer cell has on its surface the programmed death receptor, and that's in about 1/3 of lung cancers, not all of them, then that is the person that may benefit from immunotherapy, okay? The more the number of receptors, the more likely there is benefit, right? So now there are an explosion of clinical trials with anti-PD-1 drugs. And you can imagine then, if you see something that works in a person who's had a lot of chemotherapy, would it work better in somebody who's never had chemotherapy, right? So we're doing the study now, which is a national trial, which is looking at lung cancer patients, never been treated before. We get a biopsy to check for the PD-1 receptor. Half the patients get chemotherapy, half get the anti-PD-1 antibody, and we're seeing if they respond. Okay, so this is the beginning, because this is one checkpoint inhibitor, right? One drug. There are multiples, and there are others that we don't recognize. So one of the things that uniquely here for us is the radioimmunotherapy. It's the concept that radiation therapy can work in synergy with an immunotherapy drug. So we are working on a clinical trial here, which is combining radiation therapy. So the credit goes to Sylvia Fermenti, our head of radiation oncology, who described that sometimes when you have a patient with lung cancer and you have several sites and you radiate one site, another site goes away. And the only reason we do that is by the immune response, right? So what we have done is we've designed, the story is, I'll tell you, the story is I had a patient who had chemotherapy and I didn't have anything else to give him. And I managed to get him one of those checkpoint inhibitors on compassionate, and I treated him, and Sylvia radiated one spot, and surprisingly had a complete response. Complete response, right? I'd never seen that before. Well, I have, but so then, for about a year, he had no evidence of disease. And then, for some reason, he developed one lymph node recurrence. So we took out this lymph node, and this lymph node had cancer cells, and it was surrounded by the immune cells trying to kill the cancer. And so, thankfully, he's still alive and well with no evidence of disease. So we thought that was a hint. And so we designed this trial that is running now, that is recruiting patients after one course or 2 courses of chemotherapy to get this antibody. It's a different antibody than the PD-1. And then we'd radiate one spot of metastatic disease. And so look, we'll have to see how that pans out, but so far, looks okay. So immunotherapy is the next generation. And I think that, when I hear my friend at Sloan, Dr. Rizvi, who's been the principal investigator of a lot of immunotherapy trials, and he tells me that you can now cure patients. Just to be able to say that in my lifetime, I think is amazing. So I think we're getting there, and I know not fast enough for many, but as fast as we can. So that's my talk for the day. I don't have any multi-choice questions. I'm sorry, I forgot all about that, but okay.